Hi, this is John Adamson, the Rehab Documentation Guru, and today we're going to look at whether your clinical findings and your evaluation support the treatment diagnoses that you're using. And as an example, we're going to look at a particular patient. This is a PT example, and the two diagnoses used on this patient were muscle weakness, generalized, and difficulty in walking. Let me talk for a moment about generalized muscle weakness. You may have heard me say this either in my course, if you've attended that, or in another video, that muscle weakness by itself is not a good diagnosis to stand alone. What that means is that if the patient's just muscle weak, and the auditor is looking at this claim, they're going to assume that you could set up a program either carried out by the patient or by a caregiver, and in 1 to 4 visits, the patient will be sufficiently educated, or the caregiver will, to safely and effectively carry that out to take care of the muscle weakness. So by itself, we don't want muscle weakness to be the only diagnosis for treatment. Now, it's not in this case, and the therapist also noted difficulty in walking. Now, difficulty in walking differs from abnormality of gait. And a lot of people assume incorrectly that abnormality of gait necessitates a neurological diagnosis. However, that's not the case. Neurological patients that are non-neurological, in other words, they maybe have an orthopedic issue, will have abnormalities of gait. The problem is our assessment needs to prove that, and so we're going to look at that when we look at what's going on with the patient. So here we had a patient that was fairly high level with bed mobility and transfers, modified independent, and then modified independent for ambulation with front-wheeled walker times 50 feet. So they were fairly debilitated in the ambulation category. Now let's look at what's going on with them. They're unable to ambulate. So therefore, at present, when we go back to these diagnoses, difficulty in walking is appropriate. But if they're not able to ambulate, then we cannot possibly look at gait abnormality. It's not a possibility to evaluate it. So that would not be an appropriate diagnosis. Let's suppose you worked with this patient for a little bit and they did start ambulating, and you were going to do an updated plan of care on this patient, and you were able to assess their gait anomalies. Then at that point, you could add the diagnosis of abnormality of gait. That would be appropriate. Now let's look at strength. Strength bilaterally is 3 minus out of 5. Now general strength assessments are generally not very good. They're just not enough information. What we should do is joint specific and think about the movements that are really relevant to issues concerning like gait. Like if you, let's say the patient was ambulating and then you notice that they were toe dragging. Well, it would make sense to do a specific measurement of dorsiflexion in that case. Or they're having trouble advancing their leg during swing phase. Well, hip flexion would probably be a good idea to look at. So we want to, take cues from our assessment to determine what specific measurements of strength we're going to look at. Also, if the patient's strength is less than 3 out of 5, then use a goniometer to measure that. 3 minus out of 5 would be defined as anti-gravity movement greater than 50% of available range up to 99% of available range. Do you see how much leeway there is between those two measurements? There's a huge amount. And so let's say you got the patient, they're 3 minus out of 5, they get through 60% of their available range. You work with them for a little while. Now they're at 90% of their available range. Well, they're still 3 minus, but you did show improvement because they are now recruiting their muscle, their muscle fibers better. They're getting more active range of motion. If you don't use goniometry, though, you're not going to capture that, and that's important. Now, there is a missed opportunity for treatment diagnoses on this patient. Let me tell you what else was going on with this patient. They had bilateral and significantly impactful upon function pain in the hips and pain of the knees. In fact, there are bilateral knee pain and bilateral hip pain codes that could have been used, and that would have answered more complexity. And we're trying to prove complexity of the patient that makes them only safe and effective to be working with a therapist. Also, this patient had a lot of comorbidities. Let me tell you about the medical diagnosis this patient had coded by the therapist. morbid obesity. That was the only medical diagnosis. And this patient had diabetes, peripheral neuropathy, CHF, lots of different medical issues. If the therapist had done a good job of assessing areas of concern related to, let's say, peripheral neuropathy, then that would have been opportunity for additional coding. Maybe not in treatment, but certainly in medical. So anyway, lots of opportunity on this eval as it is coded and as it was documented. Not much from a support of a frequency, intensity, and duration standpoint going on. So anyway, I hope you found this video helpful. If you liked the video, please subscribe, and I'll be posting other videos with documentation review as well as live showing my face so you can see what I look like too, because I know it's boring just to look at a slide. Thanks a lot. Take care.